Usually when we talk about getting a medical diagnosis, there is this expectation of precision. Like if you fall and fracture your wrist, the X-ray shows this very clear, jagged white line.
Right, yeah, it's undeniable.
Exactly. The doctor points to it, they put a cast on it, and you move forward. It's visible, it's binary, and honestly, it's kind of comforting.
Oh, absolutely. We definitely lean toward wanting our medical answers to fit neatly into, entirely separate, well-defined boxes.
But when you step into the world of vulvar dermatosis,
Yeah.
that metaphorical X-ray machine just sort of shatters. We are looking at a diagnostic landscape that is incredibly complex.
And very messy.
Yeah, which is the entire reason we're here for this deep dive. Our mission today is to untangle this often misunderstood, highly isolating corner of medicine for you. We are looking specifically at two distinct conditions, vulvar lichen sclerosus, which we'll just refer to as LS, and vulvar lichen planus, or LP.
Right.
And we have a very specific, heavily debated medical question to answer today. Can vulvar lichen planus and vulvar lichen sclerosus overlap and coexist in the exact same patient?
Which is, it's a question that has haunted clinical practice and caused profound confusion for both doctors and patients for decades, honestly.
Decades, yeah. So to find the answer, we brought a massive stack of sources to the table today. We're pulling from the major clinical guidelines, so specifically the UK's British Association for Sexual Health and HIV, the British Association of Dermatologists, and the European clinical guidelines.
All the heavy hitters.
Right. But to really get to the ground truth, we are layering in data from a massive retrospective clinical study published in Clinical, Cosmetic, and Investigational Dermatology. We'll call it the CCID study. And it compared over 1,300 patients.
I mean, having a data set of over 1,300 patients is just a monumental resource for conditions that historically have, well, they just haven't received large-scale comparative research. It allows us to see these macro patterns that you simply can't spot in a single clinic.
And if you are listening to this, you really need to understand why diving into these macro patterns matters so much. Because these conditions are notoriously misdiagnosed.
Unacceptably so, yeah.
We are talking about patients enduring years of silent suffering. They are prescribed the wrong steroid creams, repeatedly told they just have a stubborn yeast infection, or worse, completely dismissed by their providers.
Which happens all too often.
So whether you are a medical professional trying to sharpen your diagnostic intuition, a patient advocating for your own body, or just someone fiercely curious about how medicine solves complex puzzles, this deep dive will arm you with the vocabulary and the biological understanding to cut through the confusion.
Because in this specific area of medicine, understanding the underlying mechanism of the disease is literally the only way to arrive at the correct treatment.
So before we can even begin to figure out if these two conditions can exist at the same time, we have to establish their individual profiles, right? I was reading through the British guidelines, and they paint a picture of vulvar lichen sclerosus that is severe and systemic. What is actually happening at the tissue level with LS?
Well, vulvar lichen sclerosus is a chronic autoimmune-mediated inflammatory condition. It primarily targets the anogenital region. So at tissue level, the body's immune system is essentially causing chronic inflammation in the deeper layers of the skin.
Okay.
And that inflammation triggers this massive overproduction of collagen. Clinically, this presents as pale, porcelain white plaques, and you'll often see areas of purpura too.
Wait, purpura, that's bruising, right?
Exactly. It's spontaneous bruising or bleeding right into the very fragile skin.
Wow. And the guidelines also talk about a very specific geographical pattern with this. They call it a figure-of-8 distribution.
Yes, the inflammation typically encompasses both the vulva and the perianal area, creating that distinct figure-of-8 shape. And the hallmark symptom, the thing driving patients to the doctor in the first place, is intense, unyielding itch.
Just constant.
It can be so severe that it entirely disrupts the patient's sleep cycle.
I actually want to pause on that itch for a second, because if the skin is overproducing collagen and thickening up, why is the itch so severe? It seems counterintuitive.
It does, right. But it basically comes down to nerve entrapment and the inflammatory chemicals themselves. As the skin undergoes hyperkeratosis,
Which is the thickening.
Right, it just means a massive thickening of the outer layer. So as that happens, and as the inflammation rages underneath, the nerve endings in that area become hypersensitized and physically trapped in this rigid, changed tissue. The brain interprets that distress signal as an overwhelming pruritus or itch.
Oh, that makes so much sense. And if left unchecked, that structural change leads to something much more devastating than just discomfort. The sources detail a a profound loss of normal anatomy.
Yeah. The structural erasure is one of the most tragic aspects of unmanaged LS. Because of the chronic inflammation and scarring, the body begins to essentially resorb its own tissue.
Resorb it.
Yeah, we see the resorption of the labia minora, meaning the inner lips literally shrink and disappear into the surrounding tissue. We see the midline fusion of tissues, and most critically, it often causes the sealing of the clitoral hood.
Oh my God.
Yeah, where the clitoris becomes entirely buried under fused, scarred skin.
The only way I could visualize this while reading the notes was to imagine like a slow motion, unauthorized demolition and reconstruction of a house.
That's a good way to put it.
Right. The architectural features, the doorways, the structural supports, they're just being slowly erased, plastered over, and sealed shut by a faulty construction crew.
That is a very apt way to conceptualize it, yeah.
Yeah.
It is a literal architectural erasure.
So if LS is characterized by this intense itch, the white plaques, the figure of 8, and this aggressive architectural erasure, how does lichen planus differ? Because if they are so easily confused in the clinic, I just assumed LP was like a different variation of the same biological process.
A lot of people think that, but they are biologically distinct. Lichen planus behaves very differently. On the vulva, LP has 3 main variants: classical, hypertrophic, and erosive.
Okay.
Classical might just look like typical raised bumps with some hyperpigmentation. Hypertrophic presents as thickened, warty plaques, which are highly problematic because they can actually mimic skin cancer visually.
Oh, wow.
Yeah, but the variant we really need to focus on today, because it causes the most severe vulvar symptoms, is erosive lichen planus.
Erosive, I mean, that word implies that tissue is actually breaking down rather than thickening up like it does in LS.
Exactly. Instead of the intact, pale, thickened patches we see in LS, the immune system in erosive LP aggressively attacks the basal layer of the skin.
It just destroys it.
Right. It literally strips away the protective mucosal surfaces, leaving behind raw, glazed, intensely red or purplish erosions.
You basically just have raw, exposed tissue.
Yes. And a crucial clinical clue for spotting LP is looking at the borders of those erosions. You will often find something called Wickham's striae.
Wickham's tree, right. What does that look like?
It looks like a delicate, pale, lace-like network bordering the raw areas, almost like a white spider web framing the erosion.
Okay, so we have the raw erosions and the lacy Wickham striae. But there was another major differentiator for LP in the notes that really caught my attention. It was the vulvovaginal gingival syndrome, or VVG syndrome. This means LP isn't just localized to external skin, right?
Right. VVG syndrome is a defining characteristic for many LP patients. It means the immune system isn't just attacking the vulva, it is simultaneously attacking the mucosal lining of the mouth, which is a gingiva, and the internal vaginal canal. It is a true multi-site mucosal disease.
Okay, so synthesizing this LS builds this rigid, itchy white fortress that seals over the anatomy. LP strips the fortress down entirely, leaving raw, eroded tissue, and it can attack the mouth and the internal vagina.
Perfectly summarized, yes.
But on paper, they sound like polar opposites. Why is there such a massive diagnostic battleground in the real world if they're so different?
Well, because in a clinical setting, patients rarely present as a perfect textbook case.
Right, of course.
Early disease can be incredibly subtle, and more often than not, the trauma from the patient constantly scratching the severe itch of LS, or the presence of secondary bacterial or yeast infections on top of the raw LP erosions, well, it completely masks those classic signs.
It just muddies the water.
Exactly. A doctor might just look and see generalized inflamed red skin and miss the underlying cause entirely.
Which brings us perfectly to the data from the CCID study out of the Beijing Hospital Vulvar Clinic. Looking at those 1,355 patients, there is a statistic that is genuinely hard to read.
Yeah, I know the one you mean.
LS patients face a median diagnostic delay of 5 years. That is half a decade of bouncing around the medical system, trying random treatments, before someone figures out what's actually happening.
It is a devastating delay. For LP, the delay was around 3 years, which is still unacceptably long. But that 5-year gap for LS really highlights the failure of early recognition. It is just so frequently dismissed as recurrent thrush or, contact dermatitis from a new soap.
It's heartbreaking. So how does the massive data set from this study actually help? If the visual clues are masked by scratching and infections, what underlying patterns can doctors look for to spot the difference faster?
Well, the researchers identified 3 distinct clinical signatures in the data that really cut through the visual confusion. The first signature is the age of onset.
The chronological divide.
Right. While anyone at any age can develop these conditions, the median age of onset for LS in the study was 30 years old. For LP, it was significantly older at 44 years old.
Well, that's a big jump.
It is. Statistically, we are looking at two different periods of a patient's life.
Interesting. 30 for LS, 44 for LP. What is the second signature from the data?
The symptom divide. It fundamentally comes down to the mechanism of itch versus pain. In the LS group, a staggering 92% of patients reported intense pruritus, or itch, as their primary complaint. Only 14% reported pain as their main symptom.
And that makes total sense based on what we discussed earlier,
Yeah.
with the hyperkeratosis trapping the nerves and creating that massive itch response.
Exactly. But when you look at the LP group, the numbers flip entirely. A massive 79% of LP patients reported pain.
Wow.
While they did experience some itch, the intensity was much, much lower.
And the mechanism there is obvious, too. If LP is erosive and literally stripping away the mucosal barrier, you are exposing those raw nerve endings to friction, to clothing, to urine. It's not an itch. It is a fundamental burning pain.
It's a totally different biological experience for the patient.
All right.
Which leads us to the third and perhaps most definitive clinical signature geography. We talked about the figure of 8 for LS, but the crucial dividing line in the data is the internal vagina.
The border between the outside and the inside.
Biologically, it's the border between keratinized skin, which has a tough protective outer layer, and non-keratinized mucosa, which doesn't. LS practically never crosses that boundary. It just does not involve the internal vaginal mucosa.
But LP, as we saw with the VVG syndrome, ignores that border entirely.
Aggressively ignores it. The data shows that LP involves the vaginal introitus, which is the opening, and the internal canal itself in 90% of cases.
90%. This feels like a crucial clinical breakthrough. Like if a doctor is examining a patient and sees inflammation, erosions, or scarring extending inside the vaginal canal, they can almost certainly rule out LS.
Yes.
Because the biology of LS simply doesn't operate in that internal mucosal environment.
And the guidelines are extremely firm on this point. Involvement of the vagina practically excludes lichen sclerosus. And recognizing this quickly is critical because internal erosive LP can lead to complete vaginal stenosis.
Stenosis.
Yes. If not treated aggressively, the inflammation causes the internal walls to fuse together, completely scarring and closing the vaginal canal.
Okay, so we have established these really clear boundaries. We have the clinical signatures, the age difference, the mechanical divide of itch versus pain, and the firm geographical border of the internal vagina.
Right.
But that brings us back to the core question, the entire reason we are doing this deep dive. If these biological profiles and boundaries are so well defined in the data, what happens when a patient's symptoms cross the streams?
It's the million-dollar question.
Can a patient actually suffer from vulvar lichen sclerosus and vulvar lichen planus at the exact same time?
The medical guidelines have had to evolve to answer this, and the answer is yes. The major clinical guidelines now explicitly recognize an overlap syndrome.
Literally two distinct autoimmune conditions launching a coordinated attack on the same area.
It's terrifying, but true. They cite a pivotal study by Day et al., which utilized very strict clinical and histopathological criteria.
Meaning they proved it by looking at tissue biopsies under a microscope.
Right. Exactly. They didn't just guess based on symptoms. Over a 6-year period, they identified 31 confirmed cases of comorbid vulvar LP and LS. So this isn't just a theoretical anomaly. Patients can absolutely suffer from both simultaneously.
I'm trying to visualize the biology of that. Because if LS wants to build thick, white scarred skin and LP wants to erode the skin away into raw patches, what does the overlap syndrome actually look like?
It is notoriously confusing, honestly, both to the naked eye and under the microscope. The overlap frequently presents with severe hyperkeratosis and squamous cell hyperplasia.
Let's decode squamous cell hyperplasia for a second. That just means the squamous cells, the flat cells making up the outer layers of the skin, are multiplying abnormally fast, right?
Yes. The skin is essentially panicking. In response to the dual inflammatory attack of both LS and LP, the cells multiply rapidly to try and build a defense, creating massive abnormal thickening.
So you wouldn't even see the LP erosions.
Right. You don't see the classic thin, raw erosions of pure LP because they are hidden or totally altered by the hyperkeratosis of the LS.
If the visual presentation is that chaotic, how do you even approach treating it? Because if a patient has standard LS, the gold standard treatment is an ultra-potent topical corticosteroid, right? something like clobetasol propionate.
Correct. Standard LS is usually highly responsive to clobetasol used in a tapering regimen.
What does tapering look like here?
You start strong-so daily application for a month to just shut down the localized immune response, then slowly dial it back to alternate days and eventually down to a twice-weekly maintenance dose. Most LS patients respond beautifully. The inflammation stops, the skin softens, and the architecture is preserved.
But what happens when you apply that same heavy artillery to the overlap syndrome?
Well, this is why accurate diagnosis is critical. The overlap syndrome is notorious for having a poor response to these ultra-potent steroids.
But why does it fail? If the steroid shuts down the immune response, shouldn't it work for both?
Because the body is fighting a two-front war. The hyperkeratosis, that massive thickening of the skin driven by the LS and the hyperplasia, acts almost like a shield.
Oh, so the medicine can't get through.
Exactly. It prevents the topical steroid from penetrating deeply enough to address the erosive LP inflammation occurring underneath or adjacent to it. Furthermore, LP often just requires different pharmacological mechanisms altogether.
Like what?
It might require a less potent steroid combined with an antimicrobial like Trimivate to handle secondary infections in the erosive areas. Or, if the LP is really severe, the patient may need to escalate entirely to systemic immune treatments, taking oral medications to suppress the immune system globally.
Man, so a patient with the overlap syndrome might be diligently applying their clobetasol for months, assuming they have standard LS, and wondering why they are still in agony, why the architectural loss is still progressing.
And that frustration highlights why this requires a multidisciplinary team. You have a patient doing everything right, but the biology is fighting back. You need dermatologists, gynecologists, and specialized pathologists collaborating, reviewing the biopsies, and tweaking the systemic and topical treatments until they gain control of both conditions.
Yeah. And when standard treatments fail in an overlap scenario, or when diagnosis is delayed for 5 years like we saw, what actually happens to the patient? Reading the European and BHH guidelines, it becomes blindingly clear that we are not just talking about a chronic rash.
No, not at all. The toll these conditions take alters a person's fundamental quality of life. The psychological and physical burdens are profound.
Let's look at the intimacy data because the statistics in the studies are just heartbreaking.
From a quality of life standpoint, both conditions are absolutely devastating to a patient's sexual health. The data shows sexual dysfunction in 81% of LS patients and 85% of LP patients.
Over 80% in both camps.
Yeah.
That is an overwhelming majority of patients losing a core part of their human experience.
And it is largely driven by the physical reality of the diseases. The medical term is dyspareunia, which is severe pain during intercourse.
Right.
In LP, this is directly due to the raw mucosal erosions. Any friction on tissue that has been stripped of its protective layer is agonizing. Additionally, the internal vaginal scarring and narrowing we discussed earlier can make penetration physically impossible.
And in LS, the dyspareunia is driven by that architectural loss. The skin loses its elasticity, so it tears easily, the introitus narrows, the clitoris becomes buried under scar tissue, which severely impacts sensation and engorgement. It's a mechanical failure of the anatomy caused by inflammation.
And that creates this awful cycle of anticipation of pain, which causes further muscle tension, exacerbating the pain even more. The psychosexual complaints detailed in the guidelines highlight how deeply isolating this is for patients and their relationships.
It's so isolating. But beyond the loss of intimacy and the daily chronic pain, there is a much darker cloud hanging over these diagnoses. Let's talk about the cancer risk.
Yes. Both lichen sclerosus and lichen planus carry a recognized risk of malignant transformation. Specifically, they can lead to squamous cell carcinoma, or SCC, of the vulva.
And just to explain the mechanism there for you listening, cancer is essentially a mutation of cells. When tissue is subjected to chronic, unmanaged inflammation and constant cellular turnover for years on end, the chances of a cell mutating and becoming cancerous increase dramatically.
Precisely. The chronic inflammatory environment is a catalyst for malignancy. For lichen sclerosus, the lifetime risk of developing SCC is estimated at less than 5%.
Okay, and for LP?
For lichen planus, the exact risk is heavily debated in the literature, but the guidelines note it is around 3%, particularly in patients with the hypertrophic variant where the skin is aggressively thickening.
Less than 5% and around 3%. I mean, on one hand, you could look at that and say the vast majority of patients will never develop cancer. But if you are the 1 in 20, those are not odds anyone wants to ignore.
Absolutely not. Which brings us to the most crucial takeaway regarding that cancer risk. Effective, accurate, long-term treatment is clinically proven to reduce this risk.
Because the topical steroids put out the inflammatory fire.
Exactly. Keeping the inflammation suppressed and keeping the disease in remission with the correct treatment protocol directly removes the catalyst. It significantly lowers the chance of those cells mutating into carcinoma.
Wow. So, synthesizing everything we've explored today, we set out to answer if vulvar lichen sclerosus and vulvar lichen planus can overlap.
And they can.
Yes. The medical consensus and the data confirm that not only can they coexist in a highly complex treatment-resistant overlap syndrome, but that identifying them requires looking past the surface. It requires recognizing the age of onset, understanding the biological difference between intense nerve-trapped itch and raw erosive pain.
And critically, looking for that geographical border at the internal vagina.
Right. So if there's one thing you take away from this deep dive, let it be that you do not have to accept a lack of answers. If you or someone you know is suffering in silence or has been facing a multi-year diagnostic delay being told it's just a yeast infection, you now have the exact vocabulary to change the trajectory of your care. You can take words like Wickham striae, figure of 8 distribution, squamous cell hyperplasia, and overlap syndrome directly to a doctor. You can demand a proper tissue biopsy and advocate for a multidisciplinary team.
Well said. And as we close, there is one final frontier in the research that actually offers a lot of hope for the future.
Oh, what's that?
We've spent this time talking about the surface, the skin thickening, the erosions, the topical steroid treatments, but the guidelines also touch on the underlying immunology, the actual root cause. The data notes that 61% of erosive LP patients have weak circulating basement membrane zone antibodies.
Wait, basement membrane zone?
Yeah, the basement membrane is essentially the biological glue that holds the top layer of skin to the tissue underneath. The immune system is creating antibodies that literally dissolve that glue, which is why the skin erodes away.
Oh, wow. That makes perfect sense.
Right. Conversely, LS is heavily linked to extracellular matrix protein 1 antibodies.
Which does what?
This protein is a crucial part of the scaffolding that gives skin its structure and elasticity. So the body is producing antibodies that attack its own scaffolding, leading to that massive scarring and architectural loss.
It's sabotaging its own foundations.
Exactly. The ultimate cure for these devastating conditions isn't going to be found in just formulating a stronger steroid cream. The future of dermatological care relies on cracking this very specific autoimmune code, figuring out how to stop the body from generating the antibodies that tear down its own infrastructure in the first place. That is the true frontier of this research.
That is definitely something to explore and advocate for. Thank you for joining us on this deep dive, and until next time, keep asking the hard questions.